All right, chapter 18. So we've been doing a lot of these different types of emergencies, right? So gastrointestinal and urologic emergencies. Starting with gastro, obviously gastro was stomach, right? So the abdominal pain is going to be your common complaint. Most common with these guys. Almost everything you're going to go on, some part of their stomach is going to hurt. At the same time, knowing what's causing that specific pain is going to be a lot more difficult to figure out. Just remember that you may not be able to figure that out. Okay, it's not our job to figure out the exact cause and take care of that cause. Our job is to take care of the symptoms, and if they have any life-threatening problems, fix those. There we go. Can y'all hear me all right in here?
Yes.
Okay. I gotta get used
You
to
betcha.
I gotta get used to his stuff, so it's not my little dungeon. All right. So like we learned in our little anatomy portion of the class, we've got a buttload of different organs in our abdominal cavity, right? Some of these are hollow organs, some of them are solid. A lot of them can cause life-threatening bleeding. Okay, like your liver is extremely vascular. If something happens to that, you can bleed out very easily. At the same time, those hollow organs, they can also dump whatever contents they have into your body and cause you to go septic or have any other issues. There's a couple little pictures for you. You got your liver on that right upper side. It's going to be your main contender for any kind of problems. So your GI system, obviously, when we talk about GI, we're talking about our stomach. What does our stomach do? Digest the food that we eat. Okay, starts with the process of putting the food in our mouth. Saliva starts breaking it down. Then it moves through and gets taken care of with the stomach acid, pushed through your intestines, where it absorbs the rest of the nutrients, and eventually makes its way out. That's where your liver comes in. Okay, our livers are a nice little filtration system. Okay, it's going to secrete all that bile, and then it's going to filter out anything harmful to us, like case in point, alcohol. And then it also creates all the glucose stores that we need. So if you still have your gallbladder, what it does is it keeps all that bile in there in case it needs more. A lot of times if you get your gallbladder taken out, eating tends to be a more, I guess, an entertaining thing. You usually have to go to the bathroom fairly quickly afterwards. So your small intestine, just a little bit of the anatomy to it. You got the duodenum, the jejunum, and the ileum. Okay, just the three different sections. Your large intestine contains the colon. That's where all that water gets pulled out, and we have the stool formed right there. A lot of times this is where you'll get what's called diverticulitis. You'll have those little, almost like little alcoves in your intestines. They can get blocked with any type of food particles and cause an inflammation and infection. We'll get into that a little bit later. And then your nice little spleen there has no digestive function, but it's still located there. And also, if it gets damaged, it can be extremely detrimental to you. Okay, and remember that's one of those organs that leaks stuff out into your body system. So we also know that we have the genital system, which is our reproductive organs. At least female-wise, they're located on the inside of the body. The males, ours is all located on the outside. except for the bladder and the urinary system. Everybody starts out, well, should start out with 2 kidneys. So you've got one on each side. They're all located towards the back. So when they get that flank pain, that's where that comes from. Okay. Dang it. There we go. All right. All right. So your bladder, again, this is a hollow organ. It contains all the urine that we've produced, located right there behind the pubic symphysis. So right up there on the top. All right, there's what the male version looks like. So when we get kidney stones, what happens is those kidneys are trying to filter stuff out. And what happens is it'll get stuck in those little tubes. And we're trying to force it out, and it's going to scrape against the lining. And that's where you get that bleeding in the urine. I guess it's not going to show the female version. Does anybody have any questions about the urinary system? Do we know how it operates?
All good over here.
Same.
I was gonna say most of us should be very familiar with how to make urine and how it comes out. Just be aware that if they're having abdominal pain, it's always a good thing to ask them, have they had trouble going to the bathroom? That way, if they tell you yes, it's been difficult, and if they're having that flank pain on the back, they could have had some kind of damage to the kidneys, or they could be having a kidney stone. All right. So you've got this thin little membrane called the peritoneum. It kind of covers the entire abdominal cavity, okay? The visceral peritoneum is what covers the actual organs. So you've got a layer over top and then a layer again underneath that's right on top of the organs themselves. At the same time, if you have some kind of injury or you have an infection or a stomach ulcer or anything like that, those irritants can get into the peritoneum and cause another infection there. Causes it to swell, causes it to get inflamed, and then people end up having abdominal pain. All right. So acute, it should say acute abdominal pain, but acute obviously means it started up all of a sudden. So they've never had a problem before. All of a sudden, they've now had this large amount of abdominal pain. We call that acute. Most time, they have really bad problems with it. Appendicitis, pancreatitis, liver damage. Peritonitis is another one. That's that inflammation of that peritoneum that I was talking about. So ileus, what it's talking about is the muscles become paralyzed in the intestinal wall and the intestines, and they're unable to move anything through there. So they have a potential of having a blockage build up. And they have a large amount of pain from that. They may be constipated. So another thing to ask. Diverticulitis, that's where I was talking about those little holes or alcoves in your intestines. If they get filled with any kind of debris, food particles, bacteria, eventually they'll get infected, they'll swell, and that will cause pain, and that's called diverticulitis. Cholecystitis is your gallbladder is infected. A lot of times that will happen from getting gallstones and having a blockage there. And acute appendicitis, again, another blockage issue. If it gets blocked, that appendix will begin to swell. And if it pops, then you have a lot of problems, because that one is another semi-hollow organ that will dump all that infected material into your stomach cavity. Definitely not something you want to happen. All right. So 2 different nerves for the peritoneum. You've got the parietal. It's the same ones that supply the skin of the abdomen itself. And the visceral ones are the ones supplied by the autonomic nervous system. So what that is those are the ones that don't require any kind of voluntary thought process to control. Same time, since those are all connected, that's what produces that referred pain. So when we talk about somebody having pain in the gallbladder, they may have that pain in their shoulder, kind of like what this picture has. So if you look, those nerve pathways are shared. So if somebody initially says, well, man, I just had a lot of shoulder pain, but they're also nauseated, having some flank pain or any kind of abdominal pain, it may clue you in on, oh, okay, maybe there's some kind of issue going on with the gallbladder. Good old ulcers. If anybody's had them, they're not very fun. What happens is your stomach acid starts eating away the lining. Ends up creating a small hole wherever it is. A lot of that's due to stress or excess stomach acid. Signs and symptoms are going to be the same as just about everything else. Nausea, vomiting, possibly some bleeding issues either from vomiting blood or passing dark stool. Just be aware there's not a lot that we can do for that besides treating the symptoms themselves. Gallstones, if anybody's had them, they're not fun once they block that outlet. Eventually that will cause your gallbladder to get infected, and then you have to have it removed. Pancreatitis, remember all these titus or itises, that ending always means inflammation. Okay, so if we have pancreas and pancreatitis, it's inflammation of the pancreas. Again, the majority of these will have some form of abdominal pain. Most of the time it will be associated with where that organ is located in the abdominal area, but again, some of them will have that referred pain. Appendicitis, again, abdominal pain. That one, they may have a little bit more guarding, where they keep away from you. If you're trying to come and palpate it, they may pull away from you. GI hemorrhage, most time it's due to something else. Okay, it may be due to ulcers, it may be due to cancers. It may happen quite often, it may not. It may be just spontaneous. Depending on where it is in the GI system, it could either be bright red blood they pass, or it may be dark. Just be aware that anytime you have that kind of bleeding, there's always a potential for them to go into shock. So we treat it just the same as we would if it was a traumatic bleed. You know, we're gonna obviously keep them warm, elevate their legs if we need to, get them to the hospital. All right, esophagitis. If you've ever had reflux, this can come from that. That acid comes up through the stomach, up to your esophagus, and can irritate and infect that lining. A lot of times, if they've been thrown up quite a bit, they can get esophagitis as well. Varices are probably the ones you want to be a little bit more concerned about. That's where those blood vessels have increased pressure inside them. So if anybody's ever seen like varicose veins and how they pop, varices are very much similar in fashion, except the ones in the esophagus, if they pop, most of the time they can bleed quite a bit. A lot of times this is due to cirrhosis from the liver. So anytime somebody starts complaining that they've been throwing up a little bit of blood, you know they're a known alcoholic or that they've they tell you that, or if they tell you they have cirrhosis, just be prepared for that to be the cause of that bleeding. Not much we can do to stop it since it's on the inside, aside from maybe putting an intubation tube in them, but just try to keep them stable. Again, transport to the hospital, oxygen if needed, keep them calm. So Mallory-Weiss syndrome, what it is it's where that esophagus tears. A lot of times this can be done from extreme amounts of vomiting. Very, very painful. And depending on how serious the tear is, they can bleed out from it very easy. Again, if we know that's what they've done, not much we can do about it from a EMT standpoint, other than transport to the hospital. You may be able to lean them over in a position of comfort and provide suction if it's bleeding, but that's about it. Gastroenteritis, that's really just another word for like the flu, any kind of stomach virus. Causes irritation in the stomach, nausea, vomiting, diarrhea, abdominal pain. Again, we treat that by taking vitals, providing oxygen if needed, and getting them to the hospital. Diverticulitis, again, we talked about that just a second ago. It's where it gets caught in the walls and causes inflammation. Again, all of this will have those abdominal pain symptoms. They may be throwing up, they may have diarrhea, large amounts of abdominal pain, elevated blood pressure, increased heart rate, increased respiratory rate. Hemorrhoids, if anybody's had them, they suck. A lot of times those are caused by constipation, for one. If you're pushing an extremely amount of force through there, you'll get inflammation in those vessels. Transport them as we transport everybody else. More than likely, they'll be in a position of comfort. They may not sit. They may have to lay on their side. So bladder infection, cystitis, otherwise known as UTI, is very common in nursing home patients. Most of the time you'll see this when a patient has a urinary cath, especially if it's not being taken care of well enough. That's all it's going to go into. The main thing to look for with this is obviously increased temperature. They may have low blood pressure depending on how long it's gone on, increased heart rate. They may also be altered. Ask, especially if it's at a facility, ask, well, have they ever had a UTI before? Are they on any current medications, antibiotics for it? Do they always act this way, or is this different? Can we confirm that it's a UTI with the symptoms like this? No, because it could be something else as well. It could be a stroke. It could be low blood sugar. But always keep in mind that if they have that cath, or if, unfortunately, if they look like a dirty individual, they may not take care of themselves very well. They could very well have a UTI. And it's not specific to just females, it's males get them too. So anytime you have that, ask them if they have increased urination. Sometimes they'll tell you, man, I've been going to the bathroom all the time and I just feel like I can't ever get it all out. That may be your clue as to, okay, this is a UTI. Which brings us to the kidneys. Okay, you've got your kidneys, keep us running. They help filter out fluid. They retain fluid if we need it. Keep us nice and stable, which is that homeostasis, that finely balanced point. if they happen to fail, whether that's a chronic condition or damage from a traumatic event, that uremia is where we have a buildup of the urine levels in our blood. Definitely not something you want to have. Ends up causing a lot of problems. Kidney stones do eventually grow bigger. If you drink a lot of sodas or anything like that, you have a higher tendency to have kidney stones. Unfortunately, they can be extremely painful, or they could not be. It just depends on the person. But once they cause that blockage, again, that causes failure, and we can have that uremia buildup. So again, going back to the acute versus chronic. Acute obviously means sudden onset, happened just recently. Chronic is something that happens for months, years. Think of dialysis and renal failure. Acute kidney failure can happen from anything from being septic, having some kind of traumatic injury. Most of the time, if they catch it and they get these people taken care of, they can reverse it and they won't have to go on dialysis. Those kidneys can be saved. Excuse me. But once they start having that chronic kidney failure, eventually they will be put on dialysis because those kidneys help filter everything out. They'll eventually have to have their blood cleaned through those dialysis machines. So like we said, in the abdominal cavity, we do have the reproductive organs. For the females, anytime any female of childbearing age ends up having pain, always assume that they're pregnant and always assume that it is a ectopic pregnancy, which we'll get into that in later chapters. But always assume that they're having some kind of problem related to this until you can rule it out. All right, so your aorta. So it's right there behind the peritoneum. We've talked about this a little bit before with the abdominal aortic aneurysms. If that lining gets weaker, starts ballooning out, we have a real high risk of having a major problem if that pops. Sometimes it's hard to find these, especially if it's just starting. But if you ever go to palpate somebody on the stomach and you see a pulsating mass up here, definitely don't push on it. Just leave it alone. At the same time, most of the folks that end up having them, it's been a gradual thing that has happened over a couple years. Most of the time, it doesn't happen just instantly. Excuse me. Thing about pneumonia, it can cause these other problems with the abdominal pain and cause that ileus just because pneumonia affects quite a bit. We have that buildup of lungs. We have trouble breathing. We don't get near as much oxygen to the rest of our body. At the same time, when we're trying to breathe hard like that, eventually we start using those abdominal muscles as well. So we'll be sore from that. Our body's trying to use what little oxygen it's getting, which slows down digestion, which can cause a blockage, which causes abdominal pain. Good old hernias, where any kind of organ, whether it's the intestines, anything else, pushes through an opening in a body cavity where it's not supposed to be. Sometimes, kind of like AAAs, these are real noticeable, or they're not. We just have to be careful with them. There are some that are called reducible hernias, where they can be pushed back into the cavity just fine, or they're what's called incarcerated, where they can't, they're stuck right there. Same time, if they're incarcerated, they have a potential to become what's called a strangulation injury, where that muscle or that organ has been cut off from the rest of the oxygen flow. So essentially it just kind of strangles itself, and that piece will eventually die off. So these people, if we find them, always need to be transported, regardless if they say, oh, well, it's okay, it doesn't hurt. It may not necessarily hurt, but eventually if they don't get treated or they don't get looked at, and that one was an incarcerated hernia, they could lose all that tissue. So there's a couple of different serious signs that they change. If they tell you, well, yeah, they used to always, push it in and be just fine, now they can't, that's a pretty big indicator of a problem. Obvious pain, tenderness. If the skin's red or blue, it's either become extremely infected or, again, it's dying. It's being starved of oxygen. Now we're going to go ahead and beat this dead horse with the scene size up. Make sure you consider gowns and protective covers. Okay, I know with the day and age we're living in with COVID and everything like that, we're really being cautious with everything, but a lot of these abdominal problems cause vomiting, cause diarrhea, two very highly infectious, I guess is not technically the word I'm looking for, but have the high potential to contaminate you. You could get something from them that you don't want. At the same time, some of these abdominal injuries or problems could come from some kind of traumatic injury. It could have been an assault that you were there for. Again, use all your kind of context clues, situational awareness. If you're called for an unknown problem, and you get there and there's 4 or 5 people outside yelling and screaming, it may not be just a simple abdominal pain. It may have been a fight that broke out and somebody got hit with a bat. You never know. All right. So again, our primary assessment, we have our airway and breathing. Again, if you're having abdominal pain or any pain in general, you may not be breathing very good. Okay, it might be too hard to take a deep breath. Once you get to circulation, we're going to check pulses in both arms. For one, just in case with those AAAs, sometimes you may get a different pulse or a lack of pulse in one arm versus getting one in the other. But ask about any kind of dark tarry stools, any kind of blood in their vomit, if they've been coughing up blood, anything that can kind of clue you in on to, okay, this is a GI problem. And as always, if there's a serious condition that you find or they look pretty much like the toilet, we're always going to consider immediate transport. Most time with abdominal pain, your sample history and everything will end up being focused on that abdominal area. So ask them, hey, have you had any nausea, vomiting? Have you had constipation? Have you had trouble going to the bathroom? Any weight loss without doing anything? Belching or flatulence can indicate a blockage as well. At the same time, they may end up having chest pain from it, depending on what it is. Again, with those AAAs, you can have chest pain with that as well, just from how far up it is. Excuse me. All right. So on your physical exam, obviously we're going to go and palpate. Again, be careful. Be gentle about it. We're not going in there to cram our hands down into their guts. We just want to feel if there's anything distended or anything painful. Again, if you see something that's pulsing or throbbing, obviously don't press on it. Vital signs, again, like everything else, get your blood pressures, get your heart rate. Most of these folks, again, if it's a serious condition, we're going to reassess them all the time, every 5 minutes or every time we do some type of intervention or if something changes. At the same time, some of these conditions that we find are very serious. These people may be panicking, they may be freaking out, thinking they're dying. They could very well be. We just need to make sure that we're not only trying to treat their problems, but treat the emotional state of this person as well. Don't ever sit there and if they ask you, am I going to die? Don't say, oh no, you're going to be fine. Just tell them you're going to do the best you can. Don't ever tell somebody that they're not going to die, because they will prove you wrong. Again, if you have to transport them however they're comfortable, they need to lay on their side, let them lay on their side. Whatever is easiest for them. For one, that may help reduce blood pressure and kind of ease their pain a little bit. And like we talked about at the very beginning, we're not going to be able to treat the causes of this stuff. This is stuff on the inside of the body that may have been going on for a long time. All we're doing is trying to treat the symptoms and keep them from dying. We're basically the Band-Aid, and the hospital is going to provide the definitive care for them. Be prepared for shock. Even if you don't see it right away, even if the only thing you notice is that they have an increased heart rate, go ahead and start treating for shock. The earlier the better. Okay, give them some oxygen, whether that's a nasal cannula to start with, or if eventually we need a non-rebreather, it may help them out. For one, it's also a mentality thing. If you're giving them something, saying, here, I'm going to go ahead and give you this oxygen, it's going to help make you feel better. Even if their O2 saturation is 100%, saying that may help them calm down. Again, some of these patients, depending on what it is, and realistically with everything that's going on now, you're going to clean yourself, the equipment, your hands, the ambulance, all of it, just in case we have any kind of infectious material on there. Good old dialysis. Dialysis is for end-stage renal failure. It's the only kind of treatment for those that are in kidney failure. Like I said, it filters out that blood, it cleans it, and returns it. If you've ever seen or known anybody that goes to dialysis, it's a very long process. At the same time, if they miss their appointments, they build up a lot of fluid. Those are the types of folks that you'll get that pulmonary edema. You'll get the fluid in their lungs. You may hear that from the door when you come in to assess them. They'll sound like a literal toilet bowl in their lungs. So anytime you go in and you see somebody there, always ask, can I take a blood pressure on this arm? Because if they've got their dialysis access sites on that specific side, you don't want to put the blood pressure cuff there. You don't want to screw that thing up. So make sure, if pretty much on anybody that you have any kind of indication for some kind of renal problem, that you ask. Some services do transport them to and from dialysis centers. Out here, we pick them up from the dialysis center and take them to the hospital. That's about all we do regarding dialysis centers. We don't transport to those places. Like we just talked about, dialysis machine works like the kidneys. It filters everything out. The downside to this is after they get done, they may end up having an extremely low blood pressure. They just got a bunch of fluid filtered out. That's why they're encouraged to eat and drink during the time they're getting dialysis. They may have those muscle cramps. They may feel sick. At the same time, if they haven't been properly taken care of at that place, or if they kind of rushed, they may have bleeding from that access site, or they may get infected. Again, when we see this, we're treating the symptoms, okay? Obviously, if it's bleeding, we're going to put pressure on it. We're going to try and stop it. If they're nauseated and vomiting, we do what we can for them, give them oxygen if needed, transport to the hospital. All right, let's do a little bit of review real quick. So, what lies in the retroperitoneal space? So this goes back to a little bit of your anatomy and physiology.
The pancreas. B.
B.
Yeah, we got that pancreas back there. So pancreas, kidneys, ovaries, all that stuff is behind there. So again, anytime you have some kind of lower back injury, they say, man, I got hit in the back and it is killing me. It could be any one of these things. Everything else, like the liver, stomach, all those are on the opposite side. They're in the front. So which one of those is a true hollow organ?
D.
The gallbladder.
D.
D.
Yeah. Hollow organ, like we said, it excretes bile and it stores it. All right. So, 34-year-old woman with a recent history of pelvic inflammatory disease presents with acute, severe abdominal pain. Her abdomen's distended and diffusely tender to palpation. Based on these findings, you should suspect what?
Appendicitis.
A. A.
A.
A.
Yeah. So remember that peritonitis is that inflammation of that membrane in the abdominal cavity. Most of the time, because it's that layer, it's all over the abdominal cavity. Most everything else that's on there will be associated with some other localized pain. So pancreatitis, a lot of times it can be almost dead center of the all four quadrants. Appendicitis is usually down lower on the right side, and then your gallbladder, that's the one that it can be that right side in the upper quadrant, or it can be, you can have that shoulder pain from those referred nerves. So most patients with an acute abdominal problem present with what?
A.
D.
C.
D.
Yeah. So most of the time, all the stuff, kind of injury and illness, almost immediately starts with a high heart rate.
Honey, water the flowers outside.
You may not necessarily have difficulty breathing. They may have an increased respiratory rate, but they may not actually have that true, I'm having trouble breathing. You may just be breathing real fast because it hurts. Diarrhea happens sometimes. Hypotension really just depends on what actual problem it is. Not every abdominal pain will end up having hypotension. Which following signs and symptoms would you be least likely to find in a patient with an acute abdominal problem? So this is what you're least likely to find.
B.
So you're least likely to find
B.
rapid shallow breathing.
B.
So we got a couple B's, a couple A's. So it's going to be your B. So remember, looking at it, it says soft, non-distended. So it's not tight. It's not hard. Most of the time with abdominal problems, we'll find some kind of distension to it. Everything else is included. Again, like we said, rapid shallow breathing, it's going to happen. They're in pain. Tachycardia, like we said, is one of the first indications of it. Diarrhea or constipation. Right. So, condition in which a person experiences loss of appetite.
E.
A.
D.
B.
Got a bunch of different answers. So it's going to be anorexia. And that's that loss of appetite.
So that's not a eating disorder then? Or am I getting
I mean,
confused?
it is, but it's also a condition in which they have a loss of appetite. But so remember, ileus is that paralysis of the muscles. Colic is cramping. Remember, emesis is thrown up. And then anorexia is this one. So, medical term for inflammation of the bladder.
B.
C.
Was it not cystitis?
A.
Yeah, A.
Yeah, so it's going to be acystitis. So the prefix neph is for kidneys. Chole is your gallbladder, and then diverticulitis is those, again, pouches is a good word for it. That's what I was looking for. Those pouches in the colon that end up getting inflamed with, fecal material, undigested food, stuff like that. So remember, cystitis is more commonly called a UTI. So if a hernia is incarcerated and the contents are so greatly compressed that circulation is compromised, it's said to be what?
D.
C.
B.
Go with D as well.
C.
Sure,
C.
it's being strangulated. So it's compressing everything and it's having that lack of oxygen. So when we talk about it, that incarcerated hernia is one that can't be pushed back into the body. It's stuck. If we can push it back in there, it's reducible. And then if it's being starved of oxygen, that's when it's a strangulation. 70-year-old man presents with an acute onset of severe tearing abdominal pain, radiates down his back. His blood pressure is 88/66, heart rate's 120s, breathing 26 times a minute. Treatment for this patient should be what?
A.
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 Yeah, get his hurt back to the hospital fast.
Probably not fast
Hey.
enough. So remember that severe tearing sensation is very unique to the AAA. Older folks tend to get it more often. We do need to transport them quick. Like I said, don't palpate too hard or at all if you can avoid it with these folks. We do not want to rupture that thing. What position do most patients prefer to be transported in?
B.
C.
As I say, think about when you've had a stomach ache or abdominal pain. What have you wanted?
Usually in the fetal position, cradling. So I'm surprised it wouldn't be like a recovery stage option. It's C, the other side, I guess.
Yeah, it's going to be C. Most of the time they're going to stand on that side and they're going to have their knees drawn up.
Okay. The way I found it whenever my ovaries ruptured.
Oh, really? Quoting Letterkenny.
What?
Every time they say something like can,
Made it through that one. All right.
Oh.
So chapter 19. So the endocrine system, it's our chemical messenger system. It involves your hormones, and then hematologic emergencies. For one of those are difficult to assess. Okay, it deals with your, remember, hema deals with the blood, so these are blood issues. Downside to a lot of this stuff is we're not going to be able to figure it out in the field. We're only going to be able to treat whatever signs and symptoms we can find. And those can be wildly different depending on what's being affected. At the same time, with some of this stuff, you may very well actually save their life with this. So let's start with the endocrine. Like I said, it's kind of our communication system based on hormones. Sends messages to the different parts of the body to trigger different types of reactions. Think of it like your adrenaline, fight or flight response, things like that. Whenever we have these issues, it's because of some kind of internal problem. Some kind of, gland isn't working right. It may produce more or less of an hormone. Depending on what it does, affects how well that's going to work. At the same time, if it's producing what it's supposed to be, it may be that that organ it's sending those hormones to isn't receiving it or isn't able to process it right. So like glucose is one of the most important ones. We've said it before, brain needs oxygen, needs sugar, that glucose. Insulin is what helps transport that. Okay, without it, the cells aren't going to get the glucose they need, and they're going to eventually die. It's where a pancreas comes in. The pancreas is what produces that glucagon and the insulin. It sits there and builds it up, stores it, and when it's needed, it releases whichever one it needs at that time. That's where your diabetics come into play. Depending on which type of diabetic they are, they may not be able to produce that insulin. They may not be able to use it either. We said diabetes, full word is diabetes mellitus. Again, it impairs that glucose usage. If we don't fix it, that blood sugar is going to continue to raise and raise and raise. Eventually, it can cause diabetic ketoacidosis, could put them in a coma, and eventually kill them. Like it says there, it can cause all kinds of different adverse effects: blindness, kidney failure, can be put on dialysis for it. You heal less and less. You have a prolonged healing stage. Your vascular system starts getting worse. Lots of different things come from this disease. So signs and symptoms for that blood sugar, whether it's high, whether it's low. Dumb little thing I've always learned is if they're cool and clammy, give them candy. If they're warm and dry, they have a sugar high. Most of the time when they have a high blood sugar, they're going to have that warm red skin. It's going to be dry. And if they're low, again, it's going to be cool, clammy, diaphoretic, altered mental status. So just a little dumb phrase that might help you remember that stuff. Either one can occur with each type of diabetes. Okay. And anytime you have somebody whose blood sugar is low, which realistically is anything lower than 60, definitely anything lower than 50 with signs and symptoms, always need to be treated quickly. Whether that's giving them, something to drink, if they can talk to you, oral glucose, D10 if it's an ALS truck. All these people need to be transported to the hospital, even if we do treat them and wake them up and get them feeling better. So by definition, type 1 is where the immune system's creating antibodies against those pancreatic beta cells, not getting that insulin. Most of the time, this will happen anywhere from that early childhood into being 40-ish. These are the folks that are going to have to take insulin shots. Most of the time, they'll tell you, you can ask them, hey, oh, I had diabetes. Well, do you take insulin? Yes. Okay. At the same time, they may have a pump. So anytime you see a patient and see some kind of like implant or something underneath the skin, ask them, hey, is this a medication pump? It may not be for insulin, it may be for something else, but be aware that it can be used for these. Sometimes they mess up. It could be giving them too much. It could be giving them not enough. Like we just said, most common disease for childhood. So there's your symptoms for it. They get thirsty a lot. They start peeing a bunch. They may have trouble having increased hunger. They may eat a bunch. They may have weight loss. They may be tired all the time. So some of those you wouldn't normally think would go hand in hand with increased hunger and weight loss. So just be aware if your family says, man, they've been eating a ton lately, but they're not gaining anything. They're peeing all the time. What's going on? This way you'll kind of think, oh, okay, this may be a diabetic issue. Most time it's going to be that their glucose is above normal. Kidneys are overtaxed. They're having to work far too hard, and all that glucose ends up being built up into the urine. What that does is we eventually run out of that glucose in our body. Our body says, crap, I need something else to use. What can I use? And it turns to our fat cells. And the new fad lately is that keto diet. This is what that does. It forces our body into using those fat cells. Once it does that, it produces ketones, which is that waste. Sometimes you'll notice that they have a very fruity smell to their breath, or it may smell like alcohol. And just be aware that they're not going to be able to maintain that fine balance we talked about before with the acid and the base. A lot of time, Kussmaul respirations. If you see them with this patient, what it is they start breathing faster and deeper. So most time, if you breathe fast, you really can't breathe that deep. These people can. So just be aware that if you start seeing that, that's a pretty good sign that you have a diabetic. Yeah, so DKA, I talked about this a little bit a second ago. Initially, when it starts out, it may not be that big a deal. They may have a stomach ache, they may be nauseated, they may throw up. Eventually, they can have altered mental status, or they can be unconscious, period, stop breathing. They can die from it. Most of the time, DKA is diagnosed once that blood sugar reaches over 400. I believe our glucometers still cap out at 500. So if it reads high, they could be kind of getting into this this condition. So type 2. So what happens here is that, like we said, the body's producing that insulin, but now instead of there not being enough, it's just not working. So that hormone is being sent, and those cells aren't recognizing it, therefore they're not going to use it. Pancreas ends up starting to produce more and more because the body notices, man, there's still so much sugar and glucose in the blood. What's going on? I'm obviously not making enough. So then it produces more and more insulin, which causes more of an issue. Sometimes if we catch this early on with folks, they can do exercise, they can start eating right and correct it before those receptors just completely give out and don't recognize it anymore. So some oral medications, stuff like metformin, what it does is it stimulates those receptors, gets them primed for it. That way it kind of, in a kind of dumbed down version, it kind of slaps around and says, hey, this is what you're supposed to be doing. You're supposed to be connecting with this. Go do it. And that's what it will do. Some others will kind of reduce that glucagon and glucose and decrease it so that there's not near as much in the body. At the same time, those folks can have insulin as well. Man, I can't use that mouse wheel. All right. Most of these folks are going to get diagnosed at their checkups after they've had issues. Sometimes they'll have that change in vision. They'll continue to get sick. Again, they'll heal poorly, or they'll start getting what's neuropathy, that numbness in the feet. They'll pick their feet up and won't recognize that their foot's up, and they'll start dragging it, or they'll kick it against something. Yes, ma'am. Thank you. How are you tonight? So yeah, they'll have that numbness of the feet. So symptomatic hyperglycemia. Obviously, hyper means high, and then glycemia is that sugar level. Sometimes they'll have altered mental status. If they've got type 1, at least to that ketoacidosis, they'll start peeing a bunch. Again, it could develop into altered mental status, death. And then type 2s, it's non-ketotic, I can't say that right ever, hypersimolar dehydration. They end up having that very big fluid imbalance. They'll start having increased heart rate. They'll look and act like they're dehydrated. And they'll, like I said, they'll have altered mental status. They'll be tired. They won't want to do anything. Thirsty all the time. can't seem to get enough to drink. Check on their urine. Sometimes when they end up going into this stage, they'll be peeing something. I'll say, man, this is the darkest thing I've ever seen. I'm almost peeing brown. That's a good indication that they're in this state. They may have trouble with blurriness, vision disturbances, muscle weaknesses. They could have partial paralysis of the face, of the legs, which unfortunately is a lot of the same signs and symptoms for a stroke. And eventually they could have seizures from this. So just like everything else, some of these signs and symptoms can be indicative of another problem. That's where that sample history and talking to these patients or their bystanders or getting information from the house becomes really important. All right. So again, kind of going into it with the hyperglycemia, like we said, there's too much glucose in the bloodstream. So what are we going to do? It's going to try and filter it out. It's going to try and pee all that out. At the same time, they're not going to be able to put as much fluid in. They're going to be thirsty all the time because their body is producing so much more urine to get that sugar out. Eventually, like I said, they can pass out from it, start having seizures due to that dehydration, fluid imbalance. So hypoglycemia, the biggest thing about this is when it drops too low, almost every single time these folks are going to have some kind of altered mental status. A lot of times you see this is when somebody will take their insulin and then they forget to eat, or they get sidetracked, or if they went drinking and forgot to eat. Thankfully, we can correct this one fairly easily. Most of the time, we're just going to give D10 or glucose, anything like that. But be aware when you get on scene for these altered mental status calls. Again, history taking, getting information from the family or anything around the patient will help clue you into this, because they may act completely different from what they normally do. They could be extremely aggressive. They could be combative. They could just stare straight up at the ceiling. They could be butt naked. It all depends. The brain starts acting real weird when we run out of that sugar. Eventually, if we don't get them taken care of, if they go for too long without glucose administration, they'll have severe brain damage. Again, like I said, that dumb little phrase, cool and clammy, give them candy, it's worked for me for years. They'll be extremely diaphoretic. They'll be cool. They'll be clammy. And again, they'll be altered as all get out. So we're going to give those folks glucose. And if we're going to try oral glucose, we have to make sure that they're at least alert enough to answer questions or respond to us, and that they can control their airway. We don't ever want to try and give somebody oral glucose that may end up aspirating it and causing, problems that we didn't have in the first place. So scene safety. Most folks that have diabetes and take insulin, they probably will have syringes, so be aware of it. You want to make sure you don't step on one or put your hand in the couch trying to find something, remove the patient, and get stabbed by one. But be aware of the surroundings. When you walk in and this patient's unconscious on the floor, they're not going to be able to answer you. They're not going to be able to tell you, hey, yeah, I am a diabetic. But they may have their bottle of insulin in the fridge, or they may have a sign on their fridge that says, I am a diabetic. Or they may have one of the bracelets. So just use whatever tools at your disposal and the environment itself to kind of figure out where we need to go. At the same time, don't ever forget that even if they were a diabetic and they started having low blood sugar, they could have tripped and fell and hit their head and they're unconscious because they have a brain bleed. There's always a possibility that they cause some kind of trauma to themselves as well, especially if we don't have anybody else there. Again, general impression, we want to get eyes on the patient and see what they look like, if there's anything obviously life-threatening that we need to take care of. Hopefully most of the time with these there won't be. Try and figure out how alert they are. Are they responding to you normally? Are they talking? Are they looking at you? Do you have to yell at them to get them to pay attention to you or open their eyes? Did you have to sternal rub them or give them a trap squeeze to see if they're awake, or are they just completely laid out? And once we figure that out, then you move to your airway and breathing. Treat it as we're supposed to. If they're low on O2 sat, we're going to give them oxygen. If they're not breathing very well, we're going to give them oxygen. If they're hardly breathing and they're not breathing at a decent rate, we're going to back them. Like we said, those patients that have a high blood sugar are going to have those Kussmaul respirations, that fast, deep breath, and they'll have the ketones on their breath. That's sweet. It's very, very pungent. Hypoglycemics, they'll be breathing normal, or they'll be kind of shallow. They'll be breathing too fast. Again, like we just said, if they're having trouble breathing, manage it appropriately. Just because this is one specific problem for diabetics doesn't mean we can't not take care of the other issues. So there it is, that dry, warm skin for hyperglycemia, moist, pale, diaphoretic for hypo, rapid, weak pulse. That's if that hypoglycemia has gone on for a little bit longer than we initially thought. It's very symptomatic. Again, like I said, with all these folks, we want to transport them. They need to get looked at. Just because we sit there and give them oral glucose and they wake up and say, oh, I'm good now, they may not be. If they don't eat, if they don't take their medication like they're supposed to right then and there and get back on track within 20, 30 minutes or less, we're going to be back out there again for another unresponsive person. So again, history taken, chief complaint. Obviously, if they're unresponsive, they're not going to give you a chief complaint, but talk to the family. Okay. Ask them, hey, have they eaten anything? Do they take insulin? Well, yeah, they had dinner tonight, but no, they don't take any insulin shots or anything like that. Well, then they probably have too high a blood sugar. Same time, if they tell you, you find 4 or 5 insulin syringes that have been used and there's no sign of any kind of food that's been eaten, then they're probably low. Just make sure you know what you're looking for. Again, talk to the patient like we've been hammering home the last couple lectures. Hey, what kind of medications do you take? Do you have any previous history? Do you have a history of diabetes? Are you allergic to anything? When's the last thing you ate? Have you had any problems, any illnesses, been under a lot of stress? All of that can affect that endocrine system and affect how much glucose they're putting out or how much insulin they're putting out. All right. Again, once we get into putting our hands on a patient, getting the physical exam, if they're unresponsive, we're going to check everything. We don't know what's wrong. We can assume that it's a diabetic problem, but until we really know, we need to check everything else. Like we said, they could have had some kind of traumatic injury from falling or hitting something that we didn't know about. GCS, if you guys remember the scores for it, always try to get one, especially as a baseline, because then if something has changed, whether they've gotten better or worse, you can show that to the hospital. Say, well, they started out with a GCS of 9, but once we gave them oral glucose, they started perking up. Now they got a GCS of 12. There's a couple vital sign things there. Um, Anytime we go on a diabetic, really any patient in general, we always want to try and get a blood sugar. But when you look at hypoglycemics, like we said, their respirations may not change, but they will have that cool, clammy skin. And then hyperglycemics, we'll have those Kussmaul's respirations, and then it'll be warm and dry. Anytime you use a glucometer, make sure you're using it right. Know how it works. If it tells you that it's low, well, what does low mean? What threshold does that machine have it set to? If it says high, like I said, with ours, I think it caps out at 500. If it's anything higher than 500, all it's going to read is high. Ours goes all the way down to 0. So it will never show low, but there may be some manufacturers that have included low on theirs. Most normal folks, their blood sugar should be 80 to 120. And then your neonates, which neonates are, I think, up to 1 month from birth, should be above 70. Reassessments. Again, same thing with these patients. If they're unresponsive, if they're unstable, we're going to reassess them every 5 minutes or more times. If you give them a medication, if they start responding, you're going to reassess them again. Again, if they're awake and you know their blood sugar is low and they're able to talk to you, if they can swallow and control that airway, go ahead and give them oral glucose or see if they can drink something. Whatever the current protocols that you're using will allow you to do, and then transport them. Again, like I said, if they're unresponsive, we're not going to put anything in their mouth. We don't want them to aspirate. Most of that's beyond the EMT scope. We'll end up using IV or IM medications, whether it goes in the muscle or the vein. We're going to take care of it. And if you ever have any question, if you're not sure, you can always call your medical control. That way you can say, hey, this is what I've got. This is what it looks like. What can I do for this patient? They may give you an answer that you may have not thought of. So let's say the glucometer ends up breaking or you left it somewhere. It's happened before. Do a detailed assessment. You can get the signs and symptoms. Don't necessarily give them medication, but get them to the hospital quick. Let them figure it out. Okay, we don't want to bank on the fact that, oh yeah, well they're cool and clammy and they're altered, so it's got to be diabetes. It's got to be low blood sugar. And then we give them that medication and find out later, well, it wasn't the case. You know, they had a traumatic head injury or they were septic or anything like that. So just make sure you communicate well with the hospitals if something like that has happened. Say, hey, we weren't able to test blood sugar. Our machine failed, but here's the signs and symptoms. Here's what we saw. Here's the vital signs we do have. We think it might be this. Again, sometimes even if we do get these people's blood sugar up, we may be unlucky and they may wake up and say, okay, well, I'm not going. The downside to that is if they're completely alert and oriented, they have every right to refuse. So just when that happens, make sure you document everything thoroughly. You know, tell them how many times you sat there and asked them to go to the hospital, how many times they told you no, how many times you begged them. You know, document all your vital signs, document what you did to them, stuff like that. Because you want to make sure you have an ironclad piece of documentation. That way, if they do say no and they don't go, and they turn around and die within, an hour because their blood sugar dropped back down again, and nobody came and got them, that you're at least covered. So there's your glucose. You got your dissolving gel, which is what we carry. There are chewable tablets, and then liquid. Any of those, again, you have to make sure that they are able to talk to you, they're able to respond, and they can swallow and manage their own airway. Again, should be a no-brainer, but put gloves on before you stick anything in the patient's mouth, especially if you're sticking your finger in there. Really, you shouldn't have to stick your finger in. Hang on. I guess if one of y'all wants to let the Van Winkles know that we are just about done. I guess their connection cut out. They don't necessarily have to jump back on if they can't. But just whatever your local protocol says for giving that glucose, it may have a certain threshold. It may say, well, their blood sugar has to be lower than 40 with signs and symptoms, or it may be anything less than 50 gets it. So just make sure you're aware of what you're supposed to be doing. And with these folks, again, we're going to kind of reassess them as often as we can, because you never know, they may be able to maintain their airway, but something happens and now they've aspirated or start to choke, or their sugar goes back down. So we always need to keep an eye on these folks. Again, we're going to transport them every time if we can. So if somebody starts having a seizure and they're a diabetic and they've never had seizures before, that is bad. Okay, seizures are not good. Downside is we're just going to have to manage it the way we manage normal seizures. Try to keep their airway open. Place them on their side. Don't stick anything in their mouth. They have a tendency to clench down when they're having seizures. You don't want to break their teeth, break anything off in their mouth. That can be aspirated. You don't want to lose a finger. Again, if they stop breathing or they turn blue, go ahead and start bagging them. Talked about altered mental status. All this really means is just to assess their level of consciousness. Can they talk to you right? Are they making sense? Are they alert to, the place they're at, the time they're at? Do they know who they are? Or are they just completely gorked out of their mind? Management-wise for altered mental status, we're going to try and keep them calm. And if they need additional oxygen, give them oxygen. If they start throwing up, suction them. Just kind of treating the symptoms that arise from it. So, unfortunately, when somebody is a diabetic and they have altered mental status and they're acting weird, sometimes people can confuse that with being drunk. Sometimes if they get called out for somebody in public, PD may be out there, they may be trying to contain this person and say, well, they're intoxicated. Well, they may be basing that off of the way they're acting. It may not be that they are. They may be a diabetic. Always, like we said, check a blood glucose. Okay. At the same time, they could be an alcoholic. That stuff happens with diabetes as well. But we always want to err on the side of caution and make sure that if we think they're an alcoholic, if they think they're intoxicated, let's make sure first by checking their blood sugar and rule that out. Good thing is they may not have a gag reflex. That may also be a bad thing because something might be aspirated. They may let their tongue hang back and it may block that airway. They may have snoring respirations. Again, beating a dead horse, but we're always going to kind of keep an eye on the airway. put them on their side, make sure we got suction if we need it. Does all that make sense for diabetics? Do you have any questions about diabetics?
Yeah.
Okay. Those are the most fun. I love going on diabetic calls because those are some of the coolest where we can actually see stuff work. Plus, most of the time you get them, you'll never have the same experience twice. I've had diabetics fight me. I've had naked diabetics chase after us. So I mean,
All right.
hopefully y'all get some during your clinicals.
Did you put that on me, Ricky Bobby? One of the naked man chasing me around.
Now, those are definitely fun. All right. Does anybody need a break before we jump into the next part? Or y'all good?
I'm good. It's just me though.
Good.
We're
I'm
good.
good.
Okay.
I'm good.
We're good.
All right.
I'm good.
There we go. All right. So again, hematology is the study of blood-related diseases. One of the biggest ones we've always heard about is sickle cell, hemophilia, and then thrombophilia. Again, these are a lot like the endocrine system. We won't be able to necessarily tell exactly what the cause is. It makes it kind of difficult to determine. All right. Again, we've got 4 different pieces to the puzzle here. You've got your red blood cells. That's got your hemoglobin. That's your oxygen delivery device. Our white blood cells are the ones that fight off any kind of disease or infections. Platelets form our clots. And then plasma is just kind of the fluid that helps transport everything in. So sickle cell, most of the time it's not affected by anybody here in the U.S. It's most often in Africa. Their red blood cells end up misshapen like a sickle shape, hence where the name comes from. Downside to that is it makes oxygen binding to the hemoglobin incredibly hard. They may also have clots because of the way these red blood cells are formed. So let's see. Unfortunately, most of these folks end up having a shorter lifespan than we do. More cell waste is created just simply due to the way the shape is, the lack of hemoglobin being transported. So it ends up kind of dumping and clumping into the blood. There's a couple different complications that can come from it. The biggest one down there is that vascular occlusion with ischemia. They can end up having tissue damage from that lack of oxygen. So there's a couple pictures of it. A lot of the times, anything that's associated with it is painful. Depending on what it is, like I said, with that ischemia, it can be life-threatening. They're a little bit more susceptible to infections as well due to the shape of these cells. Oh, hemophilia. If you've ever known a hemophiliac, they are bleeders. Okay. Down, man, I'm losing my mind. They're not able to clot as well. So any kind of small cut that would normally be okay for us could be life-threatening to them. They could bleed out from a very minor cut. Most time to combat this, you end up having to have that that factor 8 put in there, which is what the clotting factor is. Some people who end up having this have a specific hospital that they go to for the rest of their lives. We do have a few out here. We had somebody that worked for us that had this issue. They ended up having an ATV accident. It was very dangerous for him. But that person goes to Children's anytime they have that kind of injury to or issue to get that factor 8 put in. So thrombophilia is where hemophilia is where they bleed a lot. This one is where they clot too much. So they, instead of bleeding out, you're going to end up having blockages. Patients like this will end up taking blood thinners. They can have issues like DVTs. You'll get that clot in the deep veins. A lot of times you'll see that in like legs. People will tell you, "Oh, I got DVTs in my calves." So be aware that a lot of these are extremely painful. You may notice that there's reddening or warmness to the skin. They may end up, like I said, having blood thinners prescribed to them. They may have compression socks. Again, risk factors, like I said, if they have any kind of diabetics can have this problem. If they've had AFib, atrial fibrillation for their life, they have clotting issues there, smokers, all kinds of different stuff. Like I said, treatment-wise, anticoagulation therapy, again, blood thinners. Most time they take it for 3 months to try and get rid of it. And down there on the bottom, like it says, we just have to be careful because once they tell us, hey, I have DVTs, at any given point in time, they could have that clot travel all the way up into their lungs and cause a PE. Not much to those. Again, scene safety. Good thing is these sickle cell patients, they're probably going to be aware of it. They're going to know what's going on. Again, that goes back to talking to these patients. Wear gloves, eye protection. Try to gown up if you can. And then definitely consider ALS support, especially if they're having major problems. They can give them pain meds. If they need to give them fluids, they can. At the same time, they may not be calling just because, oh, I have sickle cell. No, I'm calling because I've had a car wreck or, got in a fight, but I just need to let you know I have sickle cell disease or I'm a hemophiliac. So the primary assessment, again, kind of the same thing we've been going through this whole time. If they're not breathing well, fix it. At the same time, they may appear to have pneumonia. They'll have that, like we said, that clumping of cells, that breakdown of cells. They may end up having fluid in the lungs. They'll have that increased heart rate. Hemophiliacs, most of the time, if you'll see them bleeding, you'll look at that cut and be like, man, they shouldn't be bleeding that bad. That may be your sign. At the same time, if they're bleeding extremely bad, you may end up having them go hypoxic. They may start turning blue. They may start having a low O2 sat because they're running out of hemoglobin to transport the oxygen. Like it says, with these folks, we need to make sure that whatever hospital we're fixing to take them to can treat that specific condition. Thankfully, both of these up here should be able to take care of it. But if you're out out way in the county, if you're up in, like Wood County or you're in Henderson, just double check with them if you're given a radio report and say, hey, this patient has a known issue. They have a sickle cell condition. Can y'all treat that? Or are y'all prepared to treat that? And if they tell you yes or no, then you can take your transport elsewhere or do what's necessary. Again, kind of look for physical signs of sickle cell crisis. Like we said, they could be looking like they have pneumonia, any kind of pain, chest pains, abdominal pains. Just be on the lookout for that. Like we said at the beginning, these two problems, endocrine and hematological, can look like a lot of other stuff, and we may not necessarily be able to guarantee that we can figure out the main problem or what the cause is. So just ask them, hey, do you hurt in one specific spot? Are you hurting all over? Any visual disturbances? Any kind of cramping, nausea, vomiting, chest pain, shortness of breath? Now, granted, if they answer yes with some of that stuff, does that, give us a clear indication of what this is? No, not necessarily. But it will help us when we're giving that information to the hospital. That's all pertinent information. Again, history taking. Ask them if this problem's happened before. Hey, have you ever had this crisis? Have you had this issue with hemophilia before? Have you had your sickle cell flare up like this? Definitely ask them how they fixed it or how it got fixed. What did they do for you? Where did you go? That way, if they already know, hey, look, I've had this problem before. They took me up to, Baylor, Dallas, or wherever, and they got me taken care of. That way you kind of have an idea, okay, they already know what to do. I'm going to go ahead and take their advice. Because most of the time with these folks that have these conditions, they're going to be far more educated than we would be. Again, focusing on the joints, because a lot of times we have buildup there with these types of patients. Again, that sickle cell, those cells are misshapen. So they may end up having pain in those joints. Check your mental status, get your vital signs, look for that sickle cell crisis. Look for weak rapid pulse, low blood pressure, anything to clue you in on, okay, this is what this is. Not necessarily so it's like, aha, I know what you have now. I can fix this. No, probably not. But we can tell the hospital and let the doctor know, and they can actually fix it. Again, reassessing vital signs. Probably, depending on how bad it is, it could be every 15 minutes. Most likely, if they're having a true crisis, it's going to be every 5. Don't be afraid to give them oxygen. Like we said, that hemoglobin is not being utilized as well, so they're going to need additional oxygen. Like we said beforehand, most of the stuff is going to be treating the symptoms. Okay, we're just kind of there as a support function. We're not going to be the end-all, be-all. Treat them. Oh, we fixed them. Great. No, we got them to the hospital alive, and the doctor was able to give them medication or do what they needed to fix these guys. All right. So type 1 diabetes is a condition in which what?
Is it B?
I don't know.
B.
Is it? You asked that like it was a question. I asked the question. You got to answer it.
Okay, the answer is B.
Be confident in your answers.
B.
Yeah. So the pancreas is failing to produce that insulin. Okay, whether it's not enough or whether it's too little. A 45-year-old man with type 1 diabetes is found unresponsive. Which of the following is most important to ask his wife?
Hey.
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 A.
A.
I was a lot more confident this time than the first question. So yeah, okay. Type 1 diabetes, he's probably going to need insulin, or he's been taking it. So we need to ask, hey, did he take it today? That way, if she tells us, well, yes, he did, okay, that may be why he's unresponsive. If he didn't take it, okay, well, maybe his sugar's too high. Now he's in DKA. Diabetic presents with a blood glucose of 310 and severe dehydration. Patient's dehydration is a result of what?
Hey.
Hey.
You can go with A as well.
Yeah, remember, so
A.
there's too much sugar in there, so now it's trying to pee it all out. Since we're trying to pee all this sugar out, our body doesn't have enough, so now our body's saying, look, I'm thirsty. Which combination of factors would most likely cause a hypoglycemic crisis in a diabetic patient?
B.
B.
No, I'm sorry, D.
C.
D.
We got some B's and D's.
B.
B.
D.
For sure.
Yeah, it's
Right now it's
Hypoglycemia.
B.
I was just saying, make sure you're looking at it right.
B.
dyslexia kicked in.
So they're a hypoglycemic crisis.
Yeah, it'd be B.
So if they skip that meal and they took their insulin, they're probably going to have a massive drop in glucose. That D, yeah, skipping a meal. Skipping a meal is bad, but not taking your insulin may kind of balance it out. You may not have that large drop in glucose. They may not feel good, but they're not going to have as big a reaction as they would if they skipped and took their insulin. 19-year-old diabetic male is found unresponsive on the couch. If you find the patient unresponsive, you should what?
D.
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 So open his airway.
I was gonna say, think of y'all's assessment when we talk about assessment.
You gotta ensure the airway for anything.
I guess B then. R.I.P.
Remember, it's ABC, airway breathing circulation. We got to have an open airway in order to ventilate for them. So always make sure that you open that airway first. Because all this other stuff, such thing can't work if his airway shut off. Same thing with oxygen. Oxygen is not going to give a big benefit if there's nowhere for it to go.
Excuse me.
So what breathing pattern would you
Well,
likely encounter in a patient with diabetic ketoacidosis? This is that. Otherwise known as Kussmaul respirations.
it's slow and irregular.
C.
C.
Because they're trying to blow off.
Yeah, so it's that fat. It's fast and deep. Remember, the Kuzmals is going to be fast and deep, and it's with that DKA. It's trying to get rid of those ketones. You also get that fruity breath. We're having that breakdown from burning off our fat stores. Woman called EMS because of her 12-year-old son. Yeah, excessive urination, thirst, and hunger for the past 36 hours.
D. Hyper.
Yeah, D.
Yeah, sir. That excessive thirst, hunger, and peeing all the time is going to be hyperglycemia. So eventually, if it continued going on, he could go into that DKA where he has that those Kuzmal respirations. Right. Cells don't receive glucose; they begin to metabolize what?
A. Fat.
A.
Hey,
Yeah, I was gonna say I just said this, so yeah, you better start burning those fat stores. And once we break that down, it creates that keto acid, those ketones. So in contrast to hyperglycemics, a hypoglycemic usually does what?
Low blood sugar.
Mm-hmm.
D.
Yes.
D.
D.
Yeah, that's the good thing about low blood sugar is most time if we can treat it, it'll come back pretty quick. All right. Patients with DKA experience polydipsia because of what?
B question mark?
Polydipsia.
A, because they're peeing all the time.
third.
That's what I would think. Hey, I'm going with A. Quick.
Yeah, again, remember that DKA, they're having a large amount of glucose and sugar in the bloodstream. So now our body's trying to get rid of it by peeing it all out. So they'll end up getting dehydrated because we're peeing so much and we're not going to be able to put enough back into our system.
Nikki said we have schedule.
So when we're dealing with a hematologic emergency or disorder,
Working nuts.
EMT must be familiar with the composition of blood. Which of the following is considered a hematologic disease?
D.
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 Both of them. All right, got sickle cell and we got hemophilia.
That's the problem.
Lou Gehrig's affects those nerve cells. All right. What are the two main components of blood?
A.
B.
Benjamin?
B.
All right.
Yeah. We got our cells, we got plasma. That plasma is the transportation medium. Those different cells, you
Think
got
about that.
those white blood cells, platelets. Assessment of patient with a hematologic disorder is the same as it is with all other patients. In addition to obtaining sample history, you should ask which of the following questions.
All of the above. E.
Nikki said you can have your schedule.
All of the above.
So
D.
that's
Yeah,
that.
you're going to answer all those. You want to know if they've had it before, or when the last time it was, and what they did for it. How it was. Again, these folks are going to be more experienced and more educated in this than we are because they deal with it every day of their life. So always ask them, hey, take care of you with this last time. And most time they'll give you a pretty direct answer. Well, this is what happened. This is what they did. This is where I went. So which of the following is not an appropriate treatment for EMTs to provide to a patient who has this type of disorder?
A.
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 Not allowed to administer.
Because unfortunately, that's out of our scope of practice. Okay? EMTs aren't able to give pain medications.
Nikki, EMT or paramedic?
Let me go ahead and pause.